Hello, and welcome to today's webinar. I am Robyn Brumble, a registered nurse and CLL Society's Director of Scientific Affairs and Research. At CLL Society, we are dedicated to bringing credible and up-to-date information to the CLL and SLL community because we believe smart patients get smart care. As a reminder, you can rewatch all of our educational programs by going to the section of our website called Education on Demand. This program was made possible through support from both our donors and our industry partners. At this time, I would like to introduce our moderator. Thank you.
Thank you, Robyn. I would like to welcome our audience and speakers to today's events. We are joined by Dr. Haidar, an infectious disease specialist, assistant professor of medicine, director of research, bone marrow transplant, and hematological malignancy infectious diseases, and also the program director of transplant infectious disease fellowship program at the University of Pittsburgh. Robyn and I were lucky to hear Dr. Haidar speak at an infectious disease conference that focused on the immunocompromised. And based on what we heard, we are excited to have him speak for us today. Also going to introduce Robyn Brumble, who's our Director of Scientific Affairs and Research at CLL Society. It is now my pleasure to introduce Dr. Haidar.
Hello, everyone. Thanks so much for having me. My name is Ghady Haidar. I'm a transplant infectious diseases physician at the University of Pittsburgh, and I'm going to be talking about COVID-19 and immunocompromised individuals. As a transplant ID doctor, the only patients I see are people with either an organ transplant or a stem cell transplant or all the hematological cancers, including people with CLL and SLL. And this is kind of a brief outline of what I'm going to be talking about. I'm going to be giving some updates about where we stand with COVID-19, some stuff about vaccines, treatments, this concept of really protracted or really prolonged SARS-CoV-2 infection in people with weak immune systems, and any trials that might be available specifically for people who are immunocompromised. And so here's where we are with COVID-19. These are data that are current as of earlier this month. And if you just look at the map of the US and you see that everything is in green, and green is good. Green means that you just have a very, very, very low number of hospitalizations for COVID-19 pretty much throughout the country, except a couple of spots out there. So things really are much better as far as COVID-19 hospitalizations and even deaths compared to before. What's interesting, though, is that only about 17% of the total eligible US population has obtained their updated boosters. But really, despite all this, things are much better than they were before. And so over here, I just want to emphasize that even though for most of the US and most of the world, things are much better when it comes to COVID-19 and there's less hospitalizations, this isn't really the case for people who are immunocompromised. And so probably about 3% of the US population has some kind of immunocompromising condition, meaning that the immune system doesn't really work the way it should. And this includes people with CLL and SLL. And according to the CDC, last year at least, about 12%, which is a decent proportion of COVID-19 hospitalizations, were in people who were immunocompromised, who were more likely to go to the ICU than people with immune systems that work, and more likely to die than people with immune systems that work. And this is regardless of whether or not these people were vaccinated. Now, it can be very difficult to track these numbers, and it's hard to find more contemporary data, but these numbers are probably similar. Even if they're a little lower, they're probably similar in the current era as to what they were last year. And all this to say that even in the current era, people who are immunocompromised are still at risk for hospitalization and death from COVID-19. And now, where are we with variants? At this stage, we really are on this sort of XBB era that has been around since earlier this year. And in these graphs, the main blue color that you see is the XBB1 variant and its various subvariants. And now, on a practical basis, aside from some minor differences in how they might present, there's really no difference in how we manage patients with COVID-19, no matter what variant they actually have, and especially if you're immunocompromised. And so, I mean, I'm going to offer you treatment no matter what the variant actually is. And I just want to remind everyone of the COVID-19 symptoms. It can really manifest like just a cold. And so here's a list of symptoms that people might get. I'm not going to read them all, but things like cough and fevers and aches and a sore throat and the issues with smell and taste and feeling tired and feeling confused, all of that stuff, which you can find in a standard non-COVID cold, in the flu and things like that. And even I feel like there's a lot of emphasis these days on specific symptoms that might be associated with specific variants, like this new XBB 1.16 variant with the conjunctivitis or the pink eye. But I mean, you can also see pink eye with other viruses as well. So all this to say that no specific symptom can rule COVID-19 in or out. And really, if you feel unwell, if you feel like you have a cold, just get tested. Actually, for the past 3 days or so, have had this runny nose, headache type stuff. And is this COVID? I don't know. So I went and got tested at home, and it was negative. So just remember that COVID really can present like a regular cold, and I think we should all have a low threshold to get tested, especially if our immune systems are weak. So now, moving on to the vaccine guidance, which I think has confused everyone, including healthcare providers, just because of all of the changes. And this is a very complex slide from the CDC website, but I feel like it is the only slide that has really clearly defined what the CDC wants us to do when it comes to the updated COVID-19 vaccines, and specifically the bivalent vaccines. And I'm not going to read through all of this because it is very complex, but the long and short of it is that we're shifting away from the original COVID-19 vaccines that came out at the end of 2020, those so-called monovalent vaccines, to the bivalent vaccines. And the simplest part of the slide is the first part on the left, where if you've never received any COVID-19 vaccine, at this stage, you're supposed to get 3 bivalent vaccine doses, either of Pfizer or of the Moderna vaccine, and then additional doses called boosters, which I'll talk about. Everything else in this slide is guidance for people who have been vaccinated. And it's really complicated. It really depends on what doses you'd received and what kind of vaccine you had received before. But ultimately, it all boils down to eventually everyone catches up with some dose of the new bivalent vaccines. And if there are specific questions, I think you can either follow the link that I have down there or also discuss with your doctors. Now, the thing is that people with weak immune systems, after they've completed their recommended bivalent vaccines, they're also eligible to receive an additional bivalent vaccine dose at least 2 months after the last recommended bivalent COVID-19 vaccine dose. So in the simplest terms, if you'd never received any COVID-19 vaccine ever, and then have received now 3 bivalent doses, 2 months after your third one, you're eligible for a 4th one, and that's considered a booster. Now, after that, the guidance is actually very unclear. And so currently the language on the CDC website is that beyond that booster, people can individualize the decision as to how many additional COVID-19 vaccine booster doses they can receive. And they've left this open-ended, and I think it's been a bit difficult to really know what to do, who to give a booster for. And I think this is probably one of the only times I've seen where the guidance has been open-ended. And these are just discussions I usually have with the patients about whether or not we want to give additional boosters or not. I've heard whispers that there might come a time where the COVID-19 vaccine might be annual. At this stage, this is not something that's set in stone. So I am very curious as to how all this might evolve over time. Now, aside from people with immunocompromising conditions being vaccinated, it's also important that the bubble be vaccinated as well. So anyone who lives in the vicinity of people who are immunocompromised should also get vaccinated. And remember that individuals who are older than 65, even if they don't have any immunocompromising conditions, they can also get an additional bivalent vaccine dose. This is at least 4 months after their last one. And so, despite vaccines, we know that people can and do still get COVID-19. And thankfully, in the current era, there's therapies that are available, each with their pros and cons. And I'm going to unpack them one by one over here. So the first one I have listed is Paxlovid, and its scientific name is listed up there. So Paxlovid is really a fantastic drug. It works very, very, very well, hence the 3 check marks under efficacy. And it's also very easy to give. It's a pill. You can just call it into your pharmacy and you can just take it. Hence the 3 check marks under ease of efficacy. But the main issue with it is drug interactions. So if you look up top at where I have Paxlovid listed, its medical name is nirmatrelvir/R. The R is something called ritonavir. And ritonavir is a is a drug that interacts very potently with many other medications that are out there. And the interaction can be so severe with these other drugs that you can actually get into issues with toxicity with these other drugs, meaning that you cannot just take Paxlovid in a vacuum. You always have to go through your provider, and they always have to make sure that Paxlovid isn't going to interact with any of the medications that you are on. Even if it does interact for most medications out there, it's okay, because what you can do is you can adjust the doses of the other drugs or stop them for a little bit while you're on the 5 days of Paxlovid. But the dangerous thing to do is to just take the Paxlovid without checking what else you might be taking. So please just keep this one in mind. This is really the only downside of Paxlovid. It's these very, very strong drug interactions with this ritonavir component. Paxlovid is considered safe during pregnancy. We have a lot of data suggesting that the ritonavir component is safe. And so it's given sort of this grade A2 recommendation by the NIH, which is one of the highest recommendations out there. The next drug is remdesivir, which works really well, but the issue is it's hard to give it because unlike Paxlovid, which is a pill, this one is IV. And it's not just a single IV dose, it's 3 IV doses, a day apart. And so you have to come into some outpatient infusion place and get an IV dose for 3 days in a row. And this has been a challenge for most places around the world, how to enforce this. But aside from that, it doesn't have any drug interactions. It's safe during pregnancy, but it gets this B2A recommendation, not because it doesn't work, but just because it's actually very difficult to give. I mean, had there been a pill version of remdesivir that works just as well, that would have been much easier. Then the next drug that I think many of us may have also heard about is called molnupiravir. And this one, the issue with it is that in the trials, it hasn't really worked as well as Paxlovid or as remdesivir, even though it's actually really easy to give because it's also a pill. It doesn't have any drug interactions, but because of the way it works, it creates all these mutations in the RNA of SARS-CoV-2. And so it's not thought to be safe during pregnancy because it might result in mutations for the unborn child. And so because of all these reasons, the safety issue and the fact that it doesn't really work as well as Paxlovid and as remdesivir, it got this kind of lowest recommendation by the NIH, which is C2A. But I will say that it's probably better than nothing if you're not pregnant. And if, let's say, you don't have access to remdesivir, and with Paxlovid, you're on some medications that are simply unsafe to use with it because of the interactions, then molnupiravir then in that setting, I think, is an option because it's better than nothing, I think. And the last drug is convalescent plasma. This one, so the concept here is that you're basically getting a bunch of antibodies from people who had recovered from COVID-19, and these antibodies are specific to COVID, and you're injecting them in someone with COVID to help them fight off the COVID-19. The data here are very limited, specifically for immunocompromised people. It seems like it might work, but we don't have these big, massive trials like we do for these other drugs. There's a lot of logistical issues around giving convalescent plasma, and so it's actually really difficult to give. It's no drug interactions, and it is safe, but the NIH says, well, because there's not a lot of evidence, we can't really make a recommendation here, but some might choose to use it. And so now I want to shift gears a bit and talk about this concept of protracted SARS-CoV-2 infection. And this isn't long COVID. So I'm not talking about long COVID where someone might get COVID-19 and then for the next few months, even longer, continue to feel maybe have some brain fog or have issues breathing. I'm not talking about that. I'm talking about a syndrome that is unique to immunocompromised patients where they can still have this active virus. So with long COVID, in general, people would have recovered from the virus months ago, but still have symptoms. With this syndrome, it's people who have weak immune systems who still have actively replicating and quote unquote alive virus that is found in them. And this is something that has been described in people with cancers, in people with organ transplants, in people with HIV/AIDS and others. There's just lots of case reports out there. And the thing is that what can happen as well is that the virus can also evolve in the patient. And there's a lot of speculation that all these variants that we're seeing now may have emerged originally from immunocompromised patients where the virus was evolving and then spread to other people. And the problem is that there aren't a lot of antivirals, and we don't really know how to manage people with this protracted infection. And so here's one example of a patient with CLL who had a very, very prolonged infection lasting over 100 days. And this, again, is active infection. And to my knowledge, the longest case report was of someone who had this active infection for 268 days. And we think this happens because the immune system is so weak that it can't actually control the virus. And this isn't the same as this Paxlovid rebound that you may have heard about, where people might take Paxlovid, get better, and then the COVID kind of wakes up again. This is more like someone who can never get rid of the SARS-CoV-2. And this gets into a problem when giving patients advice about how to go on with their lives. And our oncology group is now very aware of this syndrome, and they will often refer these patients to us really, really early. And I try to give very specific advice that is tailored to the patient's own life. And it's very difficult, I think, to tell people that they need to isolate and mask forever or up to 200 days, right? And so what I try to do is I try to explain that, listen, and you, because you keep testing positive, you might want to test yourself by the home antigen test, maybe once a week or once every 2 weeks, But as long as you're still testing positive, just be aware of the fact that you are probably still contagious. So please keep that in mind as you go about your life. And you might want to consider masking when you're outside, not just for your sake. We do still tell people who are immunocompromised to mask for their sakes, but also to just not spread the virus to others. But this is a very difficult scenario, and it's very challenging to give advice when something like this happens, because there isn't a lot of information and guidance out there. And so the other thing that there's not a lot of guidance for is how exactly we treat people with this protracted SARS-CoV-2 infection. And the drugs that I just showed you for COVID-19, these are the only drugs that are out there. So we kind of use the same drugs that are out there with some fine print. And the fine print happens because, well, there's not a lot of data. And the fine print is, some people have used combinations of antivirals, so more than one drug at the same time. The NIH is aware of this, and they say, well, we can't recommend this because a few case reports and some anecdote isn't really evidence. Some of us might give antivirals for longer than usual, so maybe longer than the 5 days of Paxlovid, but again, there isn't a lot of evidence. And then, like we talked about, there's the issue of convalescent plasma, and the NIH says, well, maybe you can try this if you have access to it. But here's, an example of what people have done. So because there aren't any trials, people have kind of tried to use some common sense and trial and error. So this was a recent paper that looked at 4 patients with B-cell cancers who had been sick with active SARS-CoV-2 infection for up to 8 months. And they all had some kind of treatments before, be it remdesivir, Paxlovid, or monoclonal antibodies back when those were available. And the patients didn't respond. And then they ultimately got up to 3 weeks of Paxlovid as opposed to the standard 5 days. And it's a bit of a complicated procedure to give that 3 weeks, but they all recovered after 3 weeks. And so maybe this might be an approach for people with weak immune systems, but there are a lot of unknowns because, again, it's only anecdotes like this that we've seen. Now, I want to shift gears for a bit and talk about other innovative treatments that we have been trying for people with weak immune systems and prolonged SARS-CoV-2 infection. And this is something called viral specific T cells, or VST. And this is a very sort of outside the box approach that we attempted because patients with weak immune systems don't really have a lot of options. And the concept here is to try to harness the immune system and get it to fight off COVID-19. And so what are these T cells? So essentially what's done is that if you look at the circle and start with the number 1 up top, we collect blood from healthy people who have recovered from COVID-19, and so who are thus immune to COVID-19 at this point. And we isolate things called T cells from them. So from their blood samples, we collect T cells. T cells are just part of the immune system that they help fight off infections. And then in the test tube, we mix these T cells with more SARS-CoV-2 to just create, frankly, these supercharged hyper SARS-CoV-2 fighting T cells. And now you have this vial of super anti-SARS-CoV-2 T cells, and you put these in a freezer somewhere. And then if you have someone who's immunocompromised and we think has prolonged SARS-CoV-2, you infuse these T cells in them with the hope that these T cells can fight off the infection. And we tried this. So over the past 2 years, we gave T cells to 6 people with immunocompromising conditions. 4 had blood cancers, 2 had lung transplants, and the results were mixed. So we had 3 people who had failed other treatments, temporarily recovered or had partial responses, but then died. We had 2 patients who completely recovered, but the thing is that they had received additional treatments kind of at the same day, so it's hard to tell what happened. And we had 1 patient who hadn't responded to 2 courses of remdesivir, and then was completely cured after the T cells. So this isn't a trial, it's just something we attempted to do, and I think there is probably a role, but these T cells aren't currently available. So it's not something that I can just prescribe to someone, and it's something that needs to be studied further, which is already happening. So on this slide, this is just a snapshot of COVID-19 trials specifically for people who are immunocompromised. And as you can see, so there's one trial looking at 5 versus 10 days of Paxlovid to really try to answer the question of, do longer durations of Paxlovid result in a higher chance of success compared to just the standard 5 days? There's a trial looking at T cells, like I just talked about. There's a trial looking at convalescent plasma. And then there's also a couple of trials of new monoclonal antibodies for prevention of COVID-19. And so to summarize, I just want to remind everyone that, again, even though the public health emergency might be done, but I don't think immunocompromised patients are out of the woods. Vaccine guidance is complicated and has changed to generally shift to the bivalent boosters. Please get your boosters, and time will tell how this will evolve annually. There are a bunch of outpatient drugs, so just get tested early and let your provider know if you test positive, and just be aware with Paxlovid that there are drug interactions. So just work with your provider to make sure that everything is being handled appropriately when it comes to any of the other meds that you are on. Remember that people with immunocompromising conditions can have this protracted SARS-CoV-2 infection, and remember that there's trials on the horizon. So thank you so much for having me. It was an honor to be here, and we now welcome Robyn Brumble with the CLL Society. Thank you.
Hello, everyone. My name is Robyn Brumble. I am CLL Society's Director of Scientific Affairs and Research. Today, I'm going to be discussing how to perform a COVID-19 personal risk assessment, especially in light of several of the changes that have occurred since the expiration of the public health emergency declaration last month, which was May. I will also be reviewing CLL Society's COVID-19 action plan. CLL Society has talked a lot about performing a personal risk assessment throughout the pandemic. One of the number one questions that we still get asked is, should I partake in this certain activity, and here are the circumstances? And you can see by the definition here, which I won't read, but you will see that the key word that repeatedly sticks out is personal. The difficulty in providing an answer to anyone as sort of one broad brush answer that applies to groups as a whole is that each person's level of risk that they're willing to accept is different. And that level of risk is going to vary depending on the circumstances. So for example, I'm going to accept a higher level of risk to go visit my granddaughter than if a friend comes to me and says that they have a free ticket to a sold out indoor rock concert and they want me to go with them. So while there unfortunately is no one formula that everyone can apply to assess risk, you've probably heard throughout the pandemic to consider sort of a list of things to do, some mental math to try to figure out how risky things might be at any given time. And some of these have historically included knowing what the rate of transmission is in the community, and if rates are particularly high, then you are encouraged to take on a lower level of risk. And we also talk about considering whether something we wanted to participate in was indoors or outdoors, and if indoors, could windows be opened, or were there HEPA filtration systems available? We also consider the size of the gathering. For instance, were we just gathering for an outdoor lunch with one friend, or are you considering going to a huge family reunion indoors with 50 people there? So we should consider if others, in addition to ourselves, are going to be masked, and if they would be willing to test and isolate prior to the gathering. That's ideal, but very few people are doing that anymore, unfortunately. And we've always historically kind of wanted to know the vaccination status of others that we were going to be around. However, many of the data points that were so ingrained in us to take into consideration to assess risk are not easily accessible anymore, especially due to the end of the public health emergency. which basically means that most of the funding for programs that were put in place during the height of the pandemic are no longer there. And one of the biggest unfortunate changes is in the ability for the CDC to collect and share data. And when they do obtain COVID-19 statistics, it's much more delayed than it used to be. And the information is usually incomplete due to several states refusing to report any longer. So we're not getting that more accurate picture of what's actually happening in the community. COVID-19 death counts are still being reported, but there's a new metric that's being used. So deaths are now usually reported weekly instead of daily, and they also lag behind. Case numbers are no longer being reported by the CDC COVID-19 data surveillance system because they don't have any authority anymore to require laboratories to report the results of the COVID-19 tests that they are running. And we'd already witnessed throughout the last year or so, since summer of 2022, that case numbers had been increasingly unreliable since home tests became more widely used, in addition to many people just stopped testing altogether. And one of the biggest changes with the end of the federal public health emergency has been surrounding access to free testing, both for those at-home tests and for tests like PCRs that were performed at labs or healthcare facilities. Private insurance companies are no longer required to cover testing for free, and any out-of-pocket costs depend entirely on an individual's healthcare plan. Those on most Medicare plans have to pay for at-home tests, but typically lab tests ordered by a healthcare provider are still fully covered. Now let's talk about what has remained the same. Hospitalizations reported by the CDC are still an accurate data point. And although it's important to keep in mind that hospitalizations and deaths have always been a lagging indicator, meaning we don't get that information until a couple weeks after cases are rising, or we don't see that rise until cases are rising. We don't see hospitalizations and deaths rise. This is a lagging indicator of how much COVID-19 is currently in the community. We can use that to assess a personal risk. But this is still, honestly, one of the fastest ways to spot changing trends in COVID-19 cases is to look at hospitalizations. Test positivity numbers remain, but they are also now lagging about 1 to 2 weeks behind, and they don't reflect an accurate picture due to, again, many states not reporting at all. This used to be an early way that we could watch for when cases were beginning to trend upward, and we don't unfortunately have that accurate information anymore. Vaccines remain mostly free for now, while government supplies remain, although there may be a fee for administration of the vaccine, depending on what your insurance plan covers. Treatments for COVID-19, such as Paxlovid, remain available while government stockpiles last. And after that time, the cost is really good. It's going to be determined by the drug manufacturer and insurance companies. But people with Medicare plans that include drug coverage will continue to have COVID-19 medications covered without cost. And thankfully, water surveillance systems are still monitoring for levels of COVID-19, and they are monitoring for what types of variants are present in the wastewater. Funding has been extended for this program through 2024, and really wastewater surveillance is probably the most accurate real-time data point that we have left that gives us an early indication of when cases are either trending upwards or downwards. Telehealth expansion coverage does remain in place for now, and this is despite the Drug Enforcement Agency proposing back in February that these flexibilities be rolled back after the end of the public health emergency. But due to all of the comments that they got, including a letter from that we signed on to a CLS society saying we would really like for them to keep telehealth options in place, they have paused stopping that program for now. The end of the public health emergency did not affect the FDA's emergency use authorization for vaccines and tests and treatments. So this still allows for the agency to authorize products and anything new that's coming down the pipeline more quickly than under the traditional approval, FDA approval process. We all became accustomed to the Swiss cheese analogy throughout the COVID-19 pandemic. If you've watched any of the previous COVID webinars CLL Society has put on, we have the Swiss cheese analogy there, which is basically just a visual tool for demonstrating that no one single action that we take to protect ourselves in and of itself is foolproof in protecting individuals from COVID-19. But rather, the more things you do, the better chances are that you're going to be able to prevent yourself from becoming infected. And there was also some degree of messaging earlier on that there was a responsibility in the community to protect those around them. But unfortunately, many of those actions of others that we used to rely upon are gone. So while the Swiss cheese approach is a great one, the slices of cheese that are remaining are only the ones that we can personally have control over to protect ourselves. So there's really been a paradigm shift to that protection now being up to each individual to decide what precautions to take, and then it's up to them to take them. So I wanted to review what these individual actions are that still provide some level of protection and remain very important, especially for immunocompromised individuals. And first, we still need to be considering our own personal level of risk. Everyone diagnosed with CLL, SLL are moderately to severely immunocompromised, regardless of their treatment status. However, we know that if someone is on certain therapies for CLL, it can further impair the immune response. So for instance, if I'm on rituximab, that would certainly need to be a factor that I take into consideration when performing my own personal risk assessment, because being on rituximab would put me at an even higher risk for poor outcomes should I become infected with COVID-19. And also, if I have other comorbidities like high blood pressure or diabetes, those types of things could put me at even higher risk if I were to become infected. And as everyone knows, masking has shifted from people around me wearing them to protect me to an emphasis on how it needs to be up to individuals to decide to protect themselves by wearing a well-fitted, high-quality face mask such as an N95. We really encourage with people not masking around you, if you haven't already, to switch to an N95. And it's also important that that N95 fits well, and there's tons of videos on how to perform a fit test on, for instance, like YouTube. There's great resources on there. We really no longer know if those around us are vaccinated or boosted. Instead, again, the responsibility falls back on us to make sure we are staying up to date with the most recent booster dose recommendations. And hopefully someday again soon, we'll have another monoclonal antibody preventative available for those of us who are immunocompromised, similar to what we previously had with the drug Evusheld. We still need to consider the space that we're going into and consider, can we personally distance ourselves, or is it going to be a very crowded area, which would come along with a higher risk? And really, knowledge is power. Having your personalized COVID-19 action plan in place, which I'm going to talk about here in a moment, is extremely important. So, for instance, do you know what to do the moment you test positive? Because we know the faster you act, the faster you get on drugs like Paxlovid, the better your outcomes are going to be. And like, do you know where to go to get Paxlovid? You know who to call, what to ask for, and really truly know how to advocate for yourself. Because sometimes having access to these things takes multiple phone calls, and you really have to advocate. And when you're performing your personal risk assessment, again, each individual has to measure what that risk benefit is going to be to you. So for example, is this something that is really important to you and you refuse to miss it, or would it just be something that's nice to do? And also, we each have to consider our own mental health as a factor, because it's not practical or healthy for anyone to remain isolated forever. I wanted to briefly go back and spend a little more time on the wastewater monitoring, because there are a couple different ones listed here. But for our COVID-19 updates throughout the winter, if you were following them, we really relied upon the BioBot analytics website, which is a good one. And here's a screenshot where you can see the two lines, and I wanted to talk about this a little bit. The blue line is the wastewater levels of COVID-19 that are present. And the teal line is the number of reported positive test results for COVID-19. And you can see earlier on in the pandemic that the waves very closely mimicked each other, because the amount in the wastewater was almost exactly the same with the number of tests that were out there. But then in the summer of 22 is when you see the shift, and wastewater was reflecting much higher rates of COVID-19 compared to the case numbers that were being reported. And again, we know this is due to people no longer testing or doing home tests. But you can still see that there are waves occurring since then. And even though COVID-19 is not in the news anymore, it is still out there. So this is a really accurate way to see the peaks in the wastewater concentrations. So I would really encourage everyone to keep an eye on this data point in particular. And if you go to the BioBot website, you can also drill down even a bit more to see specific analytics for your state and county. I also wanted to spend just a moment on masks going away in the healthcare setting. And I know some places still have them in place, especially like infusion centers and oncology clinics. But we've been receiving a lot of questions on this lately because many of you out there have noticed, even in your clinics where you're going to see your CLL doctor, that they're no longer masking. And again, going back to how to best protect yourself, we would really encourage you to still wear an N95. But you can also consider using telehealth for some of your visits when it's appropriate. Another idea is to request appointments, the first appointment early in the morning so that you're the first person to arrive in the office and the waiting room isn't full. You're not having to sit around and wait for other patients to be seen before you. And when you schedule appointments, including like dental or eye appointments, just let them know over the phone that you are immunocompromised and ask them to put a note in your chart to please have staff wear masks. And you can call or remind them that morning as well. And if you need to go to urgent care or the ER where you know there's going to be a lot of potentially sick people, when you check in, please tell them that you're severely immunocompromised and ask if you can maybe be placed in an area to wait that's more isolated and away from others. You have the right to save healthcare, but you may need to speak up and remind people. And it never hurts to ask, and I would really encourage you to do that. Now I'm going to briefly discuss CLL Society's COVID-19 action plan. The action plan is comprised of several checklists that we highly recommend individuals fill out before COVID-19 impacts your home. And if you have not already, we highly recommend that you spend some time reading through the directions and filling in the blanks as they apply to your unique situation. And then just print those checklists out, keep them in your personalized plan in an accessible place so that you can easily refer back to the plan when you need to. The first two pieces of the plan include reading through the detailed step-by-step directions, and then you're going to fill out the corresponding checklist that is called Complete Prior to Exposure. The intent of these first two documents is to really just guide you through what exactly you're going to need to do and far in advance of getting COVID-19. Some important things that these first two checklists will walk you through include looking up important phone numbers that you need to call ahead of time, or keeping suggested lists of supplies readily available, as well as how and where to quickly obtain COVID-19 testing and therapies when you need them. The next checklist includes a step-by-step guidance on how to adequately quarantine, and this is very important. I think people really took isolating and quarantine more seriously early in the pandemic, but it's still extremely important. If you're not quite sure what steps you should take to try to keep from getting COVID-19 from someone else in your home who has already tested positive, please read through this checklist so that you can be well informed and prepared. It is possible not to become infected from someone you live with if everyone in the home takes the appropriate infection control precautions as soon as infection is suspected, and especially after infection is confirmed. The next checklist is perhaps most important, and it tells you exactly what things to do after you test positive for COVID-19. And it really just serves as a really helpful step-by-step guide to remind you what to do. You can find all of these checklists on the website at cllsociety.org. As you can see in the screenshot of our website, there's a COVID-19 label located near the top of our homepage on the menu bar. If you click that button from the homepage, it will then take you to the dedicated COVID-19 section of our website. Then in the middle of the COVID-19 information page, you will see an option that says COVID-19 Action Plan. After clicking on the action plan, you'll be directed to the page where you will find all of the checklists that I have reviewed with you today. So in summary,
Please remember that it's important to continue performing your individualized COVID-19 personal risk assessment. You need to stay up to date on vaccination, continue to be diligent with infection control measures like hand washing and masking. We encourage you to revisit your COVID-19 action plan from time to time, and please make sure that it is up to date. And it's always a good idea to discuss your action plan with others in the household, just to make sure everyone knows what to do should COVID-19 ever impact your home. Thank you.
Let's start with some questions, and there's a ton. Let Dr. Haidar, the vaccinations, there's a ton on vaccines, and I'll see if I can put them all together. Two scenarios. I've had a bunch of vaccines and I have had no antibodies at all. You see this. Is it worth going for my 5th, my 6th, my 7th if I've had nothing, no response? Well, why bother?
Yeah, this is a good question. And so I'm going to answer it in two parts. One is this issue of routinely testing for antibody responses after you get a COVID-19 vaccine. And I realize this is very popular and very commonly done. It's never, even from the start, been something that I've personally recommended. And people have very strong opinions on both ends. I try not to have strong opinions about these things, but I don't find the results of antibody levels after a vaccine helpful for immunocompromised patients. And my rationale is as follows. One, I don't know what lab assay to use. So the one that you get at LabCorp is different than the one you get at Quest, is different than the one you might get at your hospital, and so on. And so I can't compare numbers. So if I get a 10 from one, I might get 1,000 from another on the exact same day. And two, I cannot tell you how well protected you are with an antibody result. And so if your antibody level, let's on some assay is 20, I can't tell you what this means when it comes to whether or not you're actually protected or how well you are protected from COVID-19. Three, even if I could tell you for one variant, we know that immunity against other variants is different. So even if I could tell you that, let's say, an antibody level from the Quest assay of 10, and I'm making this up, is very protective against Delta, it probably is not protective against Omicron. And then the issue also becomes of, this is just a snapshot in time. So how frequently do I need to keep repeating these antibody levels to tell you proactively and prospectively if you're, how well protected you are? Now, on the flip side, there's the patients who do get tested and then they have zero. So they really don't make any antibody responses. And my advice, and just as another aside, FDA and the American Society of Transplantation, and I think the ASTCT also continue to recommend against routine measurement of antibody levels. I'm well aware that it's commonly done, though. Now, if you have someone with absent, as in zero antibodies after various COVID-19 vaccines, I think in that setting, the risk of COVID is probably higher than someone who happens to get an antibody and then happens to have an antibody level detected. But I will still give both of these patients, the ones with an antibody response and the ones without, kind of the same advice of, listen, you are still going to be at risk. Because if you're immunodeficient, even if you're making an antibody, I can't tell you how well that antibody is even going to work. And so while your risk is probably lower than someone with zero antibodies, it's still there. So I try to give kind of this broad and conservative advice. And I still encourage people to get vaccinated because there's other parts of the immune system, aside from antibodies, that might be triggered by vaccines like T cells and things like that. Now, the literature on that part of the immune system, T cells in particular, is very complicated, and you will find varying and contradictory papers out there. So in our own work, we found that in general, T cell responses track with antibody responses. But if different studies have shown different things, including in patients with cancer, with some studies showing that T cell responses track with B cell or antibody responses, meaning that if you don't have an antibody, you probably don't have T cells and vice versa. Whereas others, and very well done papers as well, have shown a completely opposite response, where you find many people with no B cell or no antibody response, and yet they still have a very good T cell response. So it's messy and it's complicated, but based on all this is why I still continue to advise everyone to get a COVID-19 vaccine, even if they happen to go and check an antibody level and it's undetectable.
And I'd like to add to that, Brian, that T cell responses are also extremely important, and there aren't tests available to the general public that can measure that. So,
and LLS did do a trial on B cell lymphomas and found that a number of patients who had zero antibody response did have a T cell response. So you could be one of those. I think I already know the answer to this, but I'll just ask, because it was asked a few times. If you've had a strong antibody response, you should still get boosted, right?
Yes, please. Yeah, we're not, I mean, like I said, antibodies should in general not be used to make decisions. I know they're commonly done, but when they're done and when patients come to me with antibody results, I basically give them everything I just said. I repeat, and it's not something that should be used to decide whether or not someone needs to get a booster.
Another vaccine question, Robyn, maybe you can address this. Ingredients in the vaccines, some people are concerned that there's fetal tissue in it, that there's mercury, aluminum in it. These things have come up. Can you comment on that?
As far as the fetal tissue, my understanding is that in the original test, they used like one cell or something like that to sort of generate. It was like cells from the 1970s or something like that. Please correct me if I'm wrong, Dr. Haidar, but I would personally, I mean, that would not be a concern for me. I think that you have to also consider what the risks of getting COVID-19 are if you are not vaccinated appropriately versus risk that might be associated with, possible risk with small molecules or things that are in the vaccine. And I think by now, a lot of as we saw from our poll results, a lot of our community has received vaccines. So if you have not had some sort of odd response to something in it before, the chances are by now you're probably still not going to.
The mercury was added for when there's multiple doses in a single vial to sterilize it. It is not used, from what I understand, in any of the COVID vaccines that are used in the USA. Aluminum is used to help stimulate the immune system, and it is not used in these vaccines, so it's not an issue. The fetal tissue, from what I understand, there was fetal tissue involved in developing the vaccines, but is not in the actual vaccines. That's my understanding.
Correct.
So those are not issues. Another specific question. Should someone who's up to date with their vaccines, whatever that means, now it's complicated, should they get now it's been a couple months, should they get a bivalent vaccine, or should they wait because we heard that there's going to be a new specific vaccine this fall, or should they get both? What are you telling your immunocompromised patients, Dr. Haidar?
Yeah, this is one of the most challenging things, and I think it's the first time that I'm aware of where it's been left up to providers, this decision, because when you look at flu and now RSV and Hep B and Hep A and MMR and everything else, there's specific schedules that are followed, polio, et cetera, right? This is the first time where I've ever encountered something where it's open-ended, where it's all right, once you're caught up, 2 months later, you and the patient and their provider can individualize the decision. And I mean, the most extreme scenario there is that a person ends up getting a booster every 2 months, which I think is a lot. So at this stage, I mean, I'm having these frank discussions with patients. I've had some who have wanted to get at least one more after their last one, kind of to carry them through until the fall. Others kind of want to wait and see how things go and what the updated recs might be in the fall and winter. And if in fact, we're going to end up with this annual thing that we hear some things about. So that's the general way that we're approaching it. But it is confusing, and not just for patients, for providers as well.
People have asked what's a good source online, and I usually recommend cdc.gov. Is there another source that you'd recommend for people to get updated and quality information on vaccines, either Robyn or Dr. Haidar?
I think the CDC is a good place. I mean, yeah, that's a good place. I mean, I'd say the various cancer and transplant societies, but their recommendations usually lag behind. So I think the CDC is the best place. Yeah.
So the tests, the home tests that are available are these antigen tests. If we're not good at forming responses, are these tests as accurate in the immunocompromised as they are in the immunocompetent? Are these tests just as accurate for us, or should we be nervous about the quality of the test because we have an impaired immune system?
No, so so the home antigen tests, you're testing for the virus directly, and so there should not be any difference between immunocompromised and immunodeficient. So the immune response itself doesn't factor into that test. You're looking for the virus directly. The home antigen tests are less accurate than the PCR tests that you might get at the hospital or at an outpatient lab, because you basically need a lot more virus in your nose to pick up on it in a home test. But that applies for everyone who gets these tests.
So other than repeated testing, Robyn, do you have any advice for people who, we don't want to miss COVID, and because we know that sometimes it can just be, you got a little sniffle and a little, nothing. Is there any way other than just repeated testing to make sure you don't have a COVID infection?
I don't think there's any other way to rule it out. I mean, if you're symptomatic, if you're having a lot of symptoms, I know in the Midwest where I am, with allergies being so bad this spring, everybody had cold symptoms, right? So I think kind of knowing what your norm is, and then, if you're someone that generally goes out in masks in public and you are, not exposed to a lot of people and you're immunocompromised and you suddenly have cold symptoms, you should absolutely test. And honestly, for me personally, I would get a PCR if I were immunocompromised, because I want to make sure that I know that positive test result within the first 5 days in symptoms, so I can then get prescribed Paxlovid. So that's really why it's the most important to make sure you're getting a really good test result.
And the dosing of Paxlovid, that's 5 days, but there's an adjustment, isn't there, for people with renal disease? Am I correct on that? That was a question that was asked.
Yeah, the dose gets adjusted if there's some renal dysfunction, but it's still 5 days.
And is there somewhere, if people are worried about medication interactions, is there somewhere they can look, or a resource for them, for patients? Or
yeah, for patients gets tricky. There's a lot of medical resources out there, and actually the University of Michigan has an online PDF that I think if you just Google University of Michigan Paxlovid interaction, you'll see it. I've actually looked at that sometimes. The University of Liverpool in the UK also has a website where you can enter the drugs that you're on, and it tells you. But don't use this without talking to your providers. And in fact, it's your providers who should be telling you what to do. I think if we start getting into individual people managing their non-Paxlovid meds, you might get into a lot of issues. So just be aware of the interaction and make sure that your provider looks at it and sees what needs to be adjusted and things like that. But please don't do anything yourself.
My understanding is that there's a trial, and you mentioned this in your talk, where we're looking at 5 days versus 10, and I think there's even a 15-day cohort for the immunocompromised of Paxlovid. Is your standard still the 5-day for anyone who's immunocompromised, and then just watching?
Yeah, this is also difficult because it became.
I wasn't going to give you easy questions.
because it became clear. Well, we've known for a while about this protracted SARS-CoV-2 infection that I talked about, and so so a lot of us assumed that the 5 days of Paxlovid, while seemed fine in any people who were otherwise healthy, that in immunocompromised individuals, some of them, not all of them, might need longer. And there was a lot of trial and error here. I mean, now Paxlovid is FDA approved, and so I'm curious to see if it's going to be easier to give these longer courses, or if pharmacies are going to still only give you 5 days. I'm not sure, but we have at times given longer than 5 days. This, in the pre-approval era, this was a bit of a complicated process, and you had to actually go through the company in order to get approval. And some centers I know have given up to 3 weeks for outpatients with blood cancers and Paxlovid who didn't respond to the standard 5 days. And again, through a complicated process going through the company to get this approval. Whether or not it'll be easier to do this right now that the drug is approved, I'm not sure, but it is clear that some people do need longer than 5 days. The standard officially is still 5, but some people do need longer.
And I would recommend people look at the trial, and we have the trial on our website. If you test positive and the timing works out for you, consider entering the trial, and you will absolutely guaranteed to get 5 days. And then you don't know whether you're getting 10 or 15. You're taking pills that look the same, but you're either getting 5, 10, or 15 days of Paxlovid. And that's how we're going to answer the question. Otherwise, the question won't be answered. And this is a trial that is for immunocompromised people, and it's up on our website. So I'd recommend that. Here's the other big Paxlovid question, Robyn. Be prepared for this. What about getting it in advance? And you hinted at this. I'm going to Europe. I'm going to a wedding. I'm on the East Coast, and I'm on the West Coast. Can I put Paxlovid in my baggage because I won't have my doctor there? What about taking it not taking it prophylactically, having it with you prophylactically when you travel, especially if you're leaving the country? What is your sense of that? And because I understand now that it's approved, it's still, you'd be using it off label. You're not supposed to use it off label, but what's your approach to this? It's a very tricky area, but yeah.
Well, you wouldn't be using it off label, you'd be getting it prescribed off label.
Right. Very good point.
I think there is a difference in between what CLO Society recommends and what is the actual thing people are doing. So Brian, I know that we can talk personally about what we've done with this. I know you just traveled to Europe. And the other factor is, will your healthcare provider prescribe it? So if I'm going to the East Coast, for instance, if you have your COVID-19 action plan in there, you really should be trying to find places that you could potentially be getting prescribed while you're there, right? There's test to treat locations that you can find through the COVID-19 action plan while you're there. If I'm going to Europe, I'm not going to know where I'm going to be able to access something in Europe. So that sort of changes the scenario a little bit. You might talk to your provider about possibly having some on hand in case you test positive while you're in Europe. And then you really, if your healthcare provider decides to prescribe it for you, that's a personal decision between you and your healthcare provider. And I think you would have, Brian, I'll leave it up to you for you to say what you do in these scenarios.
Yeah, and I'll give you that same opportunity. But so as everyone knows, I have CLL, and I just came back from a conference in Switzerland and spent some vacation time in Italy. I wore an N95 mask, but I did take it off to eat and drink a little bit on the plane. I ate outdoors almost all the time, but not all the time, but almost all the time. And obviously had a mask off to eat. I was one of the only people at this hematology conference wearing a mask, but I wore a mask all the time. I had Paxlovid in my carry-on with me, just in case. and I had test kits with me just in case. And this is a question, and I'd like Dr. Haidar to lean in on this one. I used Inovid nasal spray, the Israeli nasal spray, the nitric oxide. I don't know if that helps or not, or if it's just irritating my nose, but I used that. So that's what I did when I traveled. And maybe before you answer that, Robyn, what you just came back from ASCO, which was like how many thousands of hematologists?
Almost 50,000 almost, yeah. And
Yeah.
I will say I saw probably 10 masks while I was there, so that's better than the usual conference. But I did the same thing as Brian. And with the Inovid, I think that we can't recommend it. We've said this on previous webinars. We can't recommend it. It is not FDA approved in the US. It is approved in other parts of Europe. And there have been some studies that say that the nasal spray reduces SARS viral load pretty much by more than like 95% in infected participants. So it's approved if you get infected to then use it to reduce your viral load and test negative sooner. I believe there are clinical trials ongoing in Canada right now for this. And this is not a new drug. It was used for influenza and other respiratory diseases before COVID came along.
Dr. Haidar, you want to weigh in on these travel issues? Because this has got to be something that comes up for you as caring for these patients.
I mean, I think that having a supply of Paxlovid in case you get sick outside the US, I think that's fine. And I personally have no issues prescribing that to people. I can't really comment on nasal sprays and these other interventions because I truthfully don't know a lot about that. But I also just want to caution people to not do two things with Paxlovid. Don't take it preventatively for two reasons. One, we don't know if it works that way. And two, if you actually do later on in your trip get COVID, you're out of Paxlovid. And then two, don't take it if you have a COVID exposure. There was actually a trial looking at this concept of post-exposure prophylaxis with Paxlovid, meaning that someone who was exposed to someone with COVID and then takes Paxlovid to prevent it, and it didn't work. So I think having a supply when you're out of the US where it's not going to be feasible, or you don't even know if Paxlovid exists in that country, I think that's a great idea. But only take it if you actually get COVID-19. And also, I think the idea of traveling with test kits and extra masks and things like that, I think all that makes good sense.
So a couple other meds that come up. Metformin has gotten some press recently. I know it's very early, but Dr. Haidar, you want to comment on that? Because from all the data that I've seen, the population of long COVID is enriched for the immunocompromised. Cancer patients represent a much bigger portion of those who develop long COVID. I'm not talking about carrying the virus long-term, but the post-acute sequelae, yeah.
Yeah, so metformin is interesting. I mean, it's sort of, when I first began to hear that people were looking at it into trials, I was very skeptical. It just seemed like a hydroxychloroquine again. I mean, something that I have no reason to think would have any antiviral properties, or same with ivermectin, which same concept where you have no reason to think, but that's why you do the trials and you see what happens. And interestingly, there was a big study that was published recently looking at metformin, ivermectin, and fluvoxamine to treat early COVID-19. And the main objective was to look at how many people ended up requiring oxygen, ER, hospitalization, or death. And if you look at these four outcomes, no drug had an impact. But if you take out the oxygen and just look at how many people ended up going to the ER, being hospitalized or died, there was a signal for metformin, where it does seem like there's something there. But the study wasn't specifically designed to specifically look at that question. And so this is interesting that it seems as though there's a signal there for metformin, but in my view, you probably need a trial now looking at metformin on its own and seeing what that does. I will also add that I believe that study is ongoing because they're also interested in looking at long COVID as an outcome there.
Those of us with CLL, we know we have a higher hospitalization rate. We know that we have a higher mortality rate with COVID. Could you have any up-to-date data on what's happening with CLL or with the immunocompromised? It seems like the numbers have fallen, but they're still high. Do you have a sense of where those numbers are at?
Yeah, this is a challenge because, as you heard from Ms. Brumble, no one's really obligated to report anything anymore. Kind of. I mean, I'm summarizing this, but and so the granular data that at some point I used to be able to find on the CDC website aren't really there anymore. And so you really are relying on individual cancer centers publishing their own experience with what's happening. And the bulk of what's out there, including the different types of CLL, whether you're on treatment or on observation or finished treatment, and how that impacts your risk of getting COVID and being hospitalized and dying. Most of these data are from the 2020, 2021, maybe 2022 era. I can tell you that at some point in the 2020, 2021 era, the probably 30%-ish is what I've seen as far as rates of hospitalization for people with CLL. And it does seem to be much lower in the current era, where I've seen numbers like 2 to 6%, but these are all smaller studies from individual centers. And I can also tell you just anecdotally that from our center, all COVID hospitalizations are down, including for people with immunodeficiencies, including CLL. So the trajectories mirror what you see across the US, but it's difficult, I think, to find the contemporary numbers for specific populations.
But I think it's fair to say that those numbers have fallen. I even say they plummeted. And in some studies, they're like really low single digits, but they're still 10 to 100-fold higher than the non-immunocompromised patients. So, and I think Robyn did a really nice job of kind of assessing what your risks are and how you do that. Another drug that gets mentioned a lot is immune globulin replacement, IVIG or subcutaneous immune globulin. Does that provide any protection? Some of us are getting that already because we've had recurrent infections and our immune globulin levels are low. Could you comment on the use of that?
Yeah, probably not. I mean, at this stage now, 3 years into the pandemic, you're probably at a point where the IVIG that you get probably has some COVID IgGs in there, but probably not high enough to really prevent or treat COVID-19 specifically. So I wouldn't count on current formulations of IVIG to protect or treat COVID. And I'm not aware if anyone is specifically looking at IVIG itself to prevent or treat COVID.
Yeah. Robyn, let's talk about masks for a minute. So N95s are the ideal mask. What about KN95s? Could you review, and is there any value at all to a surgical mask? And I'll throw a whole bunch of mask questions at you. And you touched on this about family members wearing masks. What about kids wearing masks? This is an issue for you as a young grandma with a baby, grandchild. How are you dealing with this personally, and what are you advising the CLL patients that you're in discussions with in terms of masking? What kind of masks? Some of these masks are uncomfortable. Oh, and I'll throw one more at you. Bearded man. This is something like somebody asked about Sikh men and they wear an extra band or something like that for the mask. So any thoughts about if you have facial hair and masking? So that's a lot there, but just sort of unpack that for me. Yeah.
Well, I think I'll leave the question about bearded men up to Dr. Haidar, but I can say absolutely, N95s are always best. you do need to make sure it's well fitted. And I think there, like I mentioned, there's videos that can show you how to do that, how to take them on, put them on, take them off appropriately. In an indoor scenario where there's lots of people, for an immunocompromised person, I think that's best case scenario. KN95s also provide good protection. They're a little bit more comfortable to wear. They don't have the rubber bands that go around your head. If you have curly hair like me, it doesn't squish your good hair day. But they can be a little irritating to your ears if you wear them long term. Surgical masks, I would say, do have a place, I think, in hospital settings, in that if someone's wearing a surgical mask, while it's not protecting them, it's catching those respiratory droplets that if they're infected, that might be flying forward towards you. So there are some value when others are wearing them, but to protect you, but they're not really going to protect the individual. The immunocompromised individual who wears a surgical mask is not going to really have that much level of protection.
Do you want to comment on the beard issue?
Yeah, so first up, I'm not immunocompromised, and the beard, during the height of COVID, I actually was clean shaven. And the reason was, if there was a lot of COVID hospitalizations, and if I was rounding in the hospital and I knew I had to go into COVID rooms, I wanted to be able to wear an N95 mask. Now, over the past year, I've grown this, and the way I approach it is a surgical mask, typically, although at our center, you're not required to wear surgical masks anymore, except our high-risk units, which are our transplant and hematological cancer units. So in those units, I wear a surgical mask with this. And if I have to go into a COVID room, I wear a PAPR. And so for people who don't know what a PAPR is, it's basically like this big hazmat type thing that connects you to this device that always has airflow in it. It's a bit of an ordeal to put on, but that's how I approach going into a COVID room at this stage, because an N95 isn't gonna make any deal with this.
I'll share this. I went to the NIH to give a talk to the hematology fellows, and a requirement at the NIH in Bethesda was that I wear the mask that they give me, which was this flimsy surgical mask. And but rather than arguing with the receptionist at the front desk, I had my N95 mask on, and I put their surgical mask, because they wouldn't let me in unless I wore their mask. But I wasn't going to take off my N95, so I put their surgical mask on top of my N95, which they had no problem with at all. But it was just, it is interesting because they insisted, but then they handed this surgical mask to you. And I've heard other people have had that issue too, where people, while we're on this, talk about surfaces. At the beginning, we were disinfecting our mail and our groceries and wearing gloves when we pump gas. And how important, Robyn, maybe you want to take this as surfaces and cleansing surfaces. And is that still as important, do we think? Where are you at with that? What are you advising people?
You don't need to spray down your groceries or anything, but I would say the most important thing is hand washing, because if you are touching surfaces that do have, fresh droplets on them or something, and you're touching your eyes or your nose or your mucous membranes, that's where that comes in. So as long as you're doing hand washing, it's great to have an extra added layer if you're at home to, you should have clean surfaces and things like that. But I don't think it's necessary to haze your house up with Lysol or anything like that. Just do good hand washing frequently. Hand sanitizer is great as well. So I think that's probably the more important aspect.
If you've had COVID, how long after should you wait to get vaccinated? Dr. Haidar, you want to take that?
Yeah, so just as soon as you recover and feel better, there's no specific time frame. I've heard some people, including healthcare workers, come to me with this notion that you have to wait a month, you have to wait 3 months. I'm not sure where these things came from, but there's no specific time frame. I mean, as soon as you feel better, you can. And remember that if you've just had COVID, you have some natural immune response as well. And so kind of the if you want to put it off longer, that's also fine.
There were some questions, and maybe I'll take this one specific to CLL in terms of, what are your risks? So remembering that all CLL patients, regardless of their treatment status, regardless if they've never had treatment, are immunocompromised. So everyone is immunocompromised, whether you're in active observation, watch and wait, in a deep remission, not on any medications, everyone's immunocompromised. That said, clearly there are degrees of immunocompromise. So if you're on a drug that depletes your B cells, like rituximab or obinutuzumab, Gazyva, you're at higher risk. And if you're on other immunocompromising therapies, if you're on certain kinds of chemotherapies and stuff, you're at higher risk with COVID. And it's not universal, and some people do very well with those, and some people who are in active observation are quite immune suppressed. Everybody is a different, one CLL patient, one CLL patient. But generally, it is different across the spectrum. And do you have anything that you would want to add to that, Dr. Haidar, Robyn, in terms of the spectrum of CLL patients in terms of their risk?
Oh, I agree.
Yeah.
Yeah, I think Brian, you hit on a point that there's so many different varying levels for each individual, and that's when it goes back to personal risk and sort of talking to your healthcare provider who knows your situation, and again, just saying, what is my level of risk? Am I on rituximab that puts me at a higher risk than but generally with a broad stroke, again, we talk about individuals are being moderately to severely immunocompromised regardless of their treatment status. Just take all of the precautions regardless of what medications you're on or not.
There's also been a concern expressed by some that getting the COVID vaccine could wake up the sleeping bear. My CLL could be stimulated again and start growing again. And there have been some anecdotal reports of people's counts going up, at least temporarily. I would respond that any immunostimulation is going to, activate the cells and get things going again a little bit. But there is no evidence that this has any significant effect on your outcome. And clearly getting COVID can be very dangerous for us. So I think getting vaccinations is much better. We only have a few minutes left, and I'm going to use that for people to summarize and give, if there's any points that we didn't get to or anything that you really want to get across. Robyn, did you want to go first and share any final thoughts that you had?
I just want to thank everyone for attending today. And Dr. Koffman, thank you for the opportunity to participate. It is always an honor to connect more directly with those that we serve in our community. And hopefully everyone who tuned into the webinar can walk away today feeling a little bit more empowered with knowledge that they gained and feel more confident in taking maybe a few more social risks, so to speak, but just keeping in mind that those risks should be considered in an informed way. And again, I said knowledge is power, and I really believe that. So it just remains important to employ strategies to mitigate risk with continued infection control precautions like masking, hand washing, ventilation, and like we've talked about, staying up to date on vaccination protocols.
I'll give you the last word, Dr. Haidar.
No, just thanks so much for having me. It's an honor to be here. I'm glad we connected in Seattle. And yeah, just to recap, I mean, yes, the public health emergency is officially over, but that doesn't mean that the virus is gone. It's here to stay, just like flu and RSV and everything else. So I think and immunodeficient people are still going to be at higher risk than people without immunocompromising conditions. Just please keep up to date on your vaccines. Hopefully the vaccination guidance will become less ambiguous later this year, but TBD, test early and let your providers know if you test positive so that they can get you treatments early. Paxlovid, remember the interactions, but please don't self-adjust any of your medications. Let your providers decide. Maybe by the end of this year, the new trial of the new version of Evusheld might be done. I don't know what the timelines are, but that's a potential new preventative drug that's on the horizon, possibly, and specifically in the trial looking at immunocompromised patients.
Yeah, so that's the Supernova trial, and I think we also have that up on our website, and that's enrolling now. It's just starting to enroll now. And there's also Invivid has a trial that's coming out for, and it'll have an immunocompromised cohort. in that too, of a different, and there's several, Robyn and I were looking yesterday, there's several other trials of monoclonal antibodies that are very interesting and very exciting. So there's a lot of reason to be optimistic that we're going to have new options. Plus there's new vaccine candidates coming that may work better in the immunocompromised, may stimulate the T cells. So there's a lot of reasons to be thankful and hopeful that things are going to get better for us. I think they already are better, but I think things could continue to get better. I couldn't ask for better faculty. Thank you so much. I think you guys were just great. I think that, this was really good learning experience. And I tried to give you all the tough questions. I want to again thank our sponsors and our donors who make this possible. Without their help, we wouldn't be able to do that. And there is a post-event survey. We really need you to complete that. It's not a long survey. Please complete that. I know that we didn't get to well over 100 questions. I mean, I lost count. So if we didn't get to your questions, please ask the expert, all one word, at clssociety.org. Join us on July 12th for Ask Me Anything, which will be more focused on CLL than on COVID, but your COVID questions will be welcome there. And I do remember, Ask Me Anything, by the way, will be Dr. Matt Davids. And if you haven't heard Dr. Matt Davids out of Dana-Farber speak, he is incredible. Just a font of CLL knowledge who presents it in a very clear and patient-friendly way. And Doreen Sunderland, who's done other events for us on Facebook, is one of the smartest patients around, and she's going to do a great job moderating that. Please remember that CLL Society is invested in your long life, and if you can invest in the long life of the CLL Society by supporting our work, we'd be extremely grateful. Stay strong. We are all in this together. Thank you so much for your attention over the last hour and a half.